Welcome, everybody. We're just going to get started now. We're so pleased that you've joined us here this evening. I'm Tammy Northam, Bladder Cancer Canada's Executive Director and your MC for this session titled Understanding the Bladder Cancer Pathway. We hope that you'll come away from tonight's webinar with a better understanding of what you should expect from your treatment pathway and practical steps you can take to ensure the best possible care and outcomes. Before we get started, we have a few housekeeping items to go over. First, to ensure the best audio experience, we have you all on mute in order to minimize background noise. Second, as indicated when you registered, we will not be able to take questions this evening as we have so many attendees on the line. However, our speakers have reviewed questions that were submitted in advance and will answer as many as possible during their presentations. If you experience technical difficulties at any point, please use the question box at the bottom of your GoToWebinar panel to communicate with us, and we will do our best to resolve the problem. Lastly, we are recording this session, so if you get disconnected, keep in mind that you'll receive the recording via email in the coming days. And now, I'd like to introduce all of our presenters for this evening at once here, starting with Dr. Nimira Alimohamed. Dr. Alimohamed is a medical oncologist at the Tom Baker Cancer Centre in Calgary, Alberta, and an associate professor in the Department of Medicine at the University of Calgary. She's involved in all levels of undergraduate, postgraduate, and continuing medical education, and serves as the Assistant Program Director for the Medical Oncology Training Program in Calgary. Dr. Alimohamed also volunteers her time and expertise as a member of Bladder Cancer Canada's Medical Advisory Board. Dr. Alimohamed led the research study which brings us here this evening, Understanding the Patient Experience with Bladder Cancer in Alberta, along with Susan Wynn, a bladder cancer survivor, and longtime bladder cancer volunteer, Marlon Gill from the University of Calgary. We're also fortunate to have two of the participants of that study with us this evening to add context based on their own bladder cancer experiences. We have Michele Zielinski, a longtime volunteer who now serves on our board of directors, and Randy Olson, a volunteer who lends his experience in the areas of IT and website management. Both Randy and Michele are also heavily involved in our in-person support group in Edmonton. Without further ado, Dr. Alimohamed, I'm just about to turn things over to you here. You'll just give me a moment. And there's our three presenters. And here we go. I will get the ball rolling here with Dr. Alimohamed.
Great. Thank you, Tammy, for the introduction. And thank you to all the participants who are taking the time to be on this webinar with us today. The goal of today's session is to go through some of the research that we did with patients to understand how the system could be better and how patients and caregivers and families can self-advocate along this bladder cancer journey. We're going to talk about our patient engagement research, which is the research study that we did. And then we'll also review through that the journey of the patient with bladder cancer. So what can you expect from our perspective, so from a physician's perspective, what are we thinking? What are our next steps in our head for someone who's diagnosed with non-muscle invasive bladder cancer, someone who has muscle invasive bladder cancer, and someone who has advanced bladder cancer? And throughout, we will highlight important aspects patients should know. So hopefully you will leave at the end of this with a good understanding of how you can help yourself along this journey. The research study that we did was trying to get an understanding of the patient experience of patients with bladder cancer in Alberta. And as Tammy mentioned, we had great help from Susan Nguyen, a bladder cancer survivor and volunteer with Bladder Cancer Canada, as well as Marlon Gill, who is well-versed and specially trained to do this type of research. We wanted to specifically identify areas that we could improve on from a system level, what was working well for patients and how could the system work better, and basically to get an understanding of what are the patients really seeing and experiencing as they go through a diagnosis of bladder cancer in Alberta. This work was supported by Alberta Health Services and the Alberta Cancer Strategic Clinical Network. With the results of this project, the goal is now to build a bladder cancer pathway to ensure that we are better and have a streamlined process for all patients in Alberta. So that's what we're working on now. How did we do this research? So we used this PACER research methodology, and PACER stands for Patient and Community Engagement Research. Basically, it takes patients and trains them to do patient-directed and patient-centered research. This is a great program that is run through the University of Calgary. We had two PACER leads, so Susan and Marlon, and they were trained to do the qualitative research. The first part of this research is where Susan and Marlon set the direction of the study together with the participants. The next part of the study is where we collect the data. So this was focus groups. So 2 focus groups and 6 individual interviews were done to basically get a sense of what's happening in Alberta. How did the patients feel? And then a final group was held to reflect on these findings together with the participants. So what I'm going to show you today encompasses all of those 3 aspects. These focus groups were held in late 2017, and patients were from urban and rural centers. We had a spectrum of patients with non-muscle invasive and muscle invasive bladder cancer. What did we find? We saw that patients really, 7 main categories emerged. The first was hematuria. So how did patients feel when they first either found blood in the urine or were told that they have blood in the urine, and what happened then? The next main category that emerged was meeting with the specialist. So what happens when you meet a urologist? What to expect? What were the good and the bad? The next main theme that emerged was a diagnosis of non-muscle invasive bladder cancer and the journey through that. And as a fourth theme was muscle invasive bladder cancer and the experience with that. And then we also heard a lot about waiting throughout the cancer journey. The patients who live perhaps not in an urban center. So what is the rural patient's experience? And a lot of patients had a lot of comments about the psychological and emotional sequelae. And I'm going to go through each of these and sort of how we can help you and how patients can help themselves throughout this. So really, the 2 primary areas of concern were from the patient's experience were how to feel connected with the healthcare team and the ease of access to information. And we're going to talk a lot about both of these. So let's start with the first theme that came about. And what I want to highlight is that this was really an Alberta experience, but I think these results are generalizable. And hopefully, as we talk, you'll be able to gain some insight and ideas that may help you as well. So when we started, the first theme was the signs and symptoms of bladder cancer when someone has hematuria or blood in the urine. This can be detected either being macroscopic, something you can see and bring to the attention of your physician, or microscopic. The blood might be detected by checking the urine. And that's how a lot of patients are diagnosed, either one of these ways. Bladder Cancer Canada has done a great job with their ad campaigns talking about hematuria. So if you see red, see your doctor. We're seeing these signs, we're seeing these posters, and some of you may have been diagnosed by seeing red in the urine and taking that to the attention of your physician. Sometimes patients did not present with hematuria, but rather other urinary symptoms like increased frequency of urination, pain with urination. And sometimes these cancers are found by accident. For example, you have a CT scan or an ultrasound done for another concern and you see a mass is found in the bladder or anywhere along the urinary tract. From a physician's perspective, it's important to note that hematuria or blood in the urine can actually be caused by many possible causes, and cancer is just one of those possible causes. When we talk about bladder cancer, we're usually talking about cancer that starts in the lining of the bladder, so what I'm pointing to here. But this lining is called the urothelium, and it's important to remember that the lining actually lines all of the urinary tract. So starting from this area of the kidney all the way down the ureter, it lines the inside of the bladder and the inside of the urethra. So some of you may be on this webinar who have been diagnosed with an upper tract urothelial carcinoma, and that most of the treatment recommendations when you get to advanced stages are the same. But going back to hematuria and many possible causes, there's lots of things that hematuria can be. So if a woman has hematuria, the first thing that a physician might think about is this patient menstruating, and we need to make sure it's not that. Some of you may or may not know, but beets can also discolor the urine. So if you've had red urine after eating a lot of beets, that might be the reason. But starting at the kidneys, there are lots of things in the kidneys that can cause red urine, including problems within the glomeruli of the kidney. And this is something which we would be led to based on looking at the urine under a microscope. Infections can cause blood, kidney stones can cause blood, or blood clots as well. Moving down the tract as well, you can have a stone in the ureter, or an infection in the ureter. All of these might lead to hematuria. Within the bladder itself, you can have bladder stones. You might have had previous radiation, which can cause some irritation or inflammation in the bladder. There's lots of other causes of inflammation in the bladder as well, which might lead to hematuria. So all of this is to say is that there's a really broad differential diagnosis for having blood in the urine, and your physician is going to think about all of these. What patients noted is that when they had blood in the urine and went to their family physician, most physicians recognized that there was the possibility of bladder cancer, but some patients found a delay in getting to the diagnosis. Most of you are past this stage now, but if there is a concern about bladder cancer, it's important to raise that with your physician. When you get to your physician, they will often do what we call a history, so ask you a lot of questions to help determine what is the cause of the hematuria. They would do a physical examination to also help guide us and decide which path should we go down. The next step is usually examination of the urine. So your doctor might send you to the lab for some blood tests as well as urine samples to check for infection. And then they might order an ultrasound or a CT scan, depending on what the history and physical exam and urine shows. The next steps are usually imaging. Based upon all of that, if there is a concern for bladder cancer, the patient is usually referred to a urologist. A urologist is a specialist in the urinary tract. These are surgeons, and usually a cystoscopy is the first step once you've met the urologist. The timelines can vary. Once you've met your family physician and done the first few steps, if things are very clear that you need to see a urologist right away, the GP will send your referral to the urologist, and that initial consultation is booked. Wait times can vary. In Alberta, it can be up to 3 months, sometimes longer, depending on the severity. And then after you meet with a urologist, usually you meet with them first in their office, and then a cystoscopy or the camera test is booked. That camera test is usually booked on its own unless someone is having a lot of bleeding. Sometimes then you skip straight to what we call a TURBT, or a transurethral resection of the bladder tumor. That is what we call a surgery. And some of our patients actually commented that when they were told that they were having a surgery or a removal of the bladder tumor, which is the TURBT, they didn't know what this would entail. And they didn't know that they weren't going to leave with incisions on their abdomen, and that this is really done through the urethra. After the TURBT is done, pathology can take a couple of weeks, and then you'll have a follow-up appointment with your urologist to review those results. So I wanted to show you kind of to make sure everyone knows the differences. So a cystoscopy is the camera test, where a camera is introduced through the urethra into the bladder. This is done in the operating room with your urologist. The urologist can then see on the screen there what it looks like inside the bladder. This is usually done with a little bit of local anesthetic or some freezing. That's different from a TURBT. This is the transurethral resection of a bladder tumor. So if you've been diagnosed with a bladder tumor based on the initial look or cystoscopy, then you would usually be booked back for a TURBT. This is the procedure where the surgeon, the urologist, will try to remove the bladder tumor, or scrape it off is sometimes what it's called. This is usually done with more anesthetic, so you might be put under general anesthesia. This would be done booked for a longer period of time in the operating room. There's no incisions on the abdomen. This is again done through the urethra, but it is a larger, more involved procedure. The next theme that came out, so once you've had the initial concern of a bladder cancer, a lot of patients commented on the patient experience. So meeting with the specialist. Patients perceived meeting the specialist usually as a very positive experience. The patients were told about the diagnosis and what the next steps were. What's important that I wanted to point out is a lot of patients, once they're told that they have a cancer diagnosis, you don't hear a lot after that word in that visit. So it's important that you bring someone with you, or have the ability to take notes and have another set of ears there for that conversation. One area I wanted to highlight was wait times. So the time to see a urologist can be variable. Like I said, it can take anywhere from, 2 weeks to 3 months in Alberta, depending on the severity. There are checks and balances in place. So if someone is having a lot of bleeding, sometimes the best step is actually to proceed to the emergency room, where the emergency room doctors would do the appropriate steps that are needed today, and then call the urologist on call or refer you appropriately. But for most patients, that wait time is appropriate. In Alberta, once you've had a cystoscopic evaluation and you need a TURBT, the median wait time to get a transurethral resection of the bladder tumor was 6 weeks, and about 90% of patients are done within 16 weeks. I'm going to talk about now the next theme which emerged, which was along the spectrum of bladder cancer in patients who are diagnosed with non-muscle invasive disease. I really want to ask all of you, if you have not done so, to look at the previous webinar by Dr. Power for more details. That is a great resource which focuses a lot on non-muscle invasive bladder cancer, how it's treated, what we do with it, etc., and also the risk of recurrence. But I'll talk about this more from the lens of our research and what patients were experiencing. Most patients who are diagnosed with bladder cancer are going to be diagnosed with non-muscle invasive disease. Most tumors are superficial, which means they have not invaded into the muscle layer of the bladder wall. Recurrences, however, are common. 60 to 70% of patients with non-muscle invasive disease will have recurrent disease. And this is really important to remember, that once you have a diagnosis of non-muscle invasive bladder cancer, it's something which needs lifelong attention. Not to say that you should be worried about it every day, but to say that you should have a plan for follow-up. Progression to more advanced stages of disease is much less common. When we talk about what determines the risk of recurrence, we look at many important factors. So what is the grade? Is it high grade? What's the stage? Is it just a carcinoma in situ, or is it a T1 disease? Is there one spot, or is it multifocal? What is the size of the tumor? And is there CIS, which is carcinoma in situ, associated with that tumor? All of those kind of worse features would have a higher risk of recurrence. So what is the risk of recurrence? We say bladder cancer is stratified into low, intermediate, or high risk non-muscle invasive disease. Low risk tumors are those which are usually low grade. They're small tumors and they're single. You don't have more than one. Intermediate risk are those tumors that have those bladders that have multiple tumors, but they don't look that aggressive under the microscope. And high risk are those tumors that have a more aggressive appearance. And the follow-up recommendations are based on which risk category you fall into. The treatment as well. So this is a slide, a snapshot taken from Dr. Power's presentation, and he goes through very well sort of what the estimated risk of recurrence and progression is. So if someone has a low risk tumor, their risk of recurrence at the 1 year mark is only about 15% and still only about 30% at the 5 year mark. And the risk of progression to more advanced stages of disease is very low. That is in contrast to patients who have a high risk tumor, which has a higher risk of recurrence within the first year and 5 years, and again, a higher risk of progression to more advanced diseases. So obviously the follow-up guidelines and recommendations are different just based on how the initial pathology is. You might hear these terms throughout your journey. Intravesicular therapy. And this is treatment that is given directly into the bladder. So some patients might receive or might have a discussion about BCG. BCG is a live vaccine and it was actually developed as a vaccine against tuberculosis. In patients with bladder cancer, it may be given directly into the bladder. So a catheter is placed in, and BCG is in a liquid form and is passed into the bladder. This is done in a suite where a cystoscopy might be done. Patients are then asked to perhaps move around to get the BCG to all parts of the bladder, and then you're asked to hold your urine for a certain period of time. The way that this works is that it triggers an immune response from your immune system to those bladder cancer cells that are there. This might be done over a span of weekly for several weeks and on a directed schedule thereafter. That's the most common form of intravesicular therapy. This is done again directly into the bladder. Other intravesicular treatments which might be given are some forms of chemotherapy, such as mitomycin C and epirubicin, or gemcitabine and docetaxel. There are potential side effects that can happen from any of these treatments. Usually they're localized to the bladder, perhaps some discomfort or burning in the bladder, or increased frequency of urination. So if you are getting any of these treatments, it's important to ask what potential side effects you can expect to confirm if you're unsure, is this just a treatment that's being given into the bladder, or is it treatment which is given intravenously? For patients with non-muscle invasive bladder cancer, one of the most common areas of concern is how to monitor for recurrence, and what are some recommended guidelines. And again, Dr. Power's presentation goes through this in detail, but I wanted to highlight some important features. So for patients who have low risk tumors, usually the evaluations are every 3 months initially, then annually after that 9-month mark. For patients with intermediate risk disease, cystoscopies are usually performed every 3 months for the first 1 to 2 years, and then every 6 months for another 2 years, and then annually. And patients might be recommended to have imaging, so an ultrasound or a CT scan of the upper tract, which is the kidneys and the ureters as well. Patients with high risk disease have scopes more frequently, so every 3 months for 2 years, and then every 6 months for another 2 years, and then annually. And again, these are just guidelines. So you will make a plan with your urologist, but these are just guidelines. And if you're not sure, you can refer to these guidelines or these webinars to make sure that you're on track. Don't be afraid to speak up and ask your urologist. Some patients, when they went into this journey, or even when they were diagnosed with non-muscle invasive bladder cancer, weren't aware that this would be kind of lifelong evaluations to monitor for progression. So this slide sort of is there to show you a lot of themes which emerged throughout the patient experience. So patients' perception and knowledge of treatment was really important. So it was really important for our patients to know where to go for information. And we will have some summary slides on this at the end, but where to go for information and how to access the information they need. Patients after a cystoscopy and after a TURBT are usually sent home that day, if not the next day after. And where do you go for help after this? A lot of patients commented that dignity is really important throughout this process. So cystoscopic evaluations or scopes are not the most comfortable procedure. Patients commented that a lot of times the care is great, but sometimes you need to speak up for yourself and say, you know, I'm a little bit cold, I could use an extra blanket, or When do I really need to get the gown on while I'm waiting? And don't be afraid to ask those questions. Most healthcare providers are busy doing their jobs and may not know what you're experiencing at that time. And it may be as simple as just voicing your comfort or discomfort in order to be most comfortable. So in order to self-advocate for a patient with non-muscle invasive bladder cancer, it's really important to get the right information at the right time. Make a list of questions, think about the physician as well as coming from a perspective of having a lot of patients to see and look after. Familiarize yourself with the guidelines with which we've talked about. In Alberta, we have now an app through Alberta Health Services that is there really for you to record the discussions you're having with your healthcare team so you can reference that later. Bring someone with you, take notes. Really important questions to ask before you leave the urologist's office is who's arranging the next test and when will that be? Who can I call if I don't hear anything? And who can I call if we need something? Speak up if you're uncomfortable. Your healthcare team is there for you, and perhaps sometimes we just don't know what's making you uncomfortable or what we could do to make your experience better. So with that, I will hand it over to Randy, who will talk about things from his perspective as a patient with non-muscle invasive bladder cancer.
Thanks, Nimira. It's Randy Olson here. I'm a male, age 68. I was diagnosed with blood in my urine in June of 2017. And I've had 4 turbots since in the last 4 years. And I've had about 3 cystos per year. My last, I've had a turbot in July of 2018, and after that turbot, they instilled some epirubicin in the bladder. I've had a couple of sessions of BCG treatments, 6 weeks each, one in April, May of 2018, and then the last one was in November and December of 2018, and they had 1/3 BCG with interferon mixed in. My last turbot was performed on November 8th, and now I'm currently waiting for a CT scan to determine if there's any other growths in the upper urinary tract. I'm extremely pleased with my medical support team in Alberta. I did have a bit of an anxiety at the very beginning. Just once I got diagnosed, I wanted to make sure everything was done as quickly as possible. And was indicated that my first turbot, I'd have to wait at least 8 weeks due to a shortage of surgery hours available at the hospital. But I intervened with my family doctor and I was able to get the turbot done the same week. So that worked out well. I really didn't know a whole bunch about the BCG installation procedure, and with a little bit of research on the internet, I was able to find out about that. I certainly have some anxiety about the high rate of recurrence and any possible prevention options, including diet or exercise or whatever that may help me in the future. My recommendations are to make sure you ask as many questions as you can until you get all your answers. Write down your questions. Record your conversation with your urologist or your medical support team. Review the bladder cancer website. Contact them for peer-to-peer support. Join a support group or attend a support group of your own, and give back at the annual BCC walk, Make Bladder Cancer a Memory. So thanks very much, and we'll turn it back to Nimira.
Thanks, Randy. All right, so now we'll transition to talking about patients who have muscle-invasive bladder cancer. So muscle-invasive bladder cancer is disease that has spread to the muscle layer or beyond. So you can see here in this diagram that now we're talking about T2. So when we talk about the stage of the tumor, this is staged as a T2 or a tumor depth of invasion that's into the muscle layer of the bladder. Patients with muscle-invasive bladder cancer, how is that diagnosed? That's diagnosed from the turbot, the TURBT. That sample is sent off to the pathologist. Most patients have non-muscle invasive bladder cancer, that is T1 or lower, but if you have a diagnosis of muscle-invasive bladder cancer, there is a different treatment approach. So this is treatment that now is more complicated than having repeat TURBTs or treatment into the bladder alone. Most of these patients will definitely need a CT scan, and at times, depending on the center you're at, you may be referred from one urologist to another for further treatment. So we now know that urologists who do a certain number of bladder cancer surgeries, removal of the bladder per year, are the ones who should be doing these. So depending on your center, depending on the urologist who you initially meet, it might be a different urologist who you would speak to about treatment for muscle-invasive bladder cancer. Remember, what we're talking about today are in our general guidelines, but your treatment plan will be very individualized, and it is very individualized based on your medical history, your wishes, and your bladder cancer itself. The general treatment approaches, when we think about muscle-invasive bladder cancer, most patients will be recommended to have surgery, which is removal of the bladder or radical cystectomy with a lymph node dissection, versus having a bladder-sparing approach, which is also a reasonable option for some patients. And that really is where we talk about chemotherapy and radiation, so radiation at high doses to kill those cancer cells within the bladder and try to preserve the bladder. This is sometimes referred to as trimodality treatment as well. When we talk about surgery, most patients will have a discussion about neoadjuvant chemotherapy, which is chemotherapy before surgery to try to improve the chances of survival. So let's talk a little bit about a radical cystectomy with pelvic lymph node removal. This is removal of the bladder and the lymph nodes in the pelvis. This is a major operation and patients need to be fit for surgery. So if a patient has lots of medical comorbidities, so for example, if you've had multiple heart issues or breathing issues in the past, perhaps this is not the best option for you. The goal of this treatment is cure. So it is difficult treatment, but the goal of the treatment is hopefully that the cancer would not come back in the future. Patients are left with either a stoma, so a pouch where the urine drains into after the surgery, that is most common, or a neobladder, which is tissue that is made to form a new bladder, and patients are then trained how to use this neobladder. And again, these are discussions that you would have with the urologist about these different options. The recovery time can be significant. What I've listed here is kind of the recovery time in hospital. So most patients are in hospital on average for about a week, and most patients are recommended to take at least 6 weeks off of work. Most patients will say that it takes at least 2 to 3 months before they have a reasonable level of energy, before their bowels are working back to normal. And sometimes it can take a lot longer, anywhere from 6 months to a year, before you feel back to what we call a new normal. So you won't be urinating the same as you ever did before. And it can take a lot of time before your energy levels recover to where they were before this major surgery. What is neoadjuvant chemotherapy? So neoadjuvant chemotherapy is chemotherapy that is delivered before surgery. There are lots of reasons for doing this, and this has really been shown to improve outcomes in patients who are fit for this treatment and fit for surgery. So how would this work? So how does the pathway work? Usually after the TURBT, you would meet with your urologist to review the results. The urologist would tell you that you've got muscle-invasive bladder cancer, and they're going to refer you to a medical oncologist to discuss the chemotherapy part of it. You would then be referred to a cancer center to meet with a medical oncologist. Sometimes we're thought of as chemotherapy doctors. If you and your oncologist decide that chemotherapy is the right option for you, that can take anywhere from 8 to 12 weeks of actual treatment. There might be some more scans, like a CT scan of the chest that has to be done before that, more blood work, sometimes more testing to check your hearing and kidney function, and then the chemotherapy itself is given intravenously over a span of 8 to 12 weeks. Once that's done and once you've recovered, it's usually about a month or 6 weeks before the actual surgery then happens. Neoadjuvant chemotherapy is not for everyone. So patients have to have good kidney function. They have to not have any significant hearing loss because the chemotherapy can lead to hearing loss, and it can be more pronounced in people who have baseline hearing issues. And neuropathy can also be a problem. So neuropathy is where someone has damage to the nerves. Usually it's most important in the fingertips and toes. So if you have a history of diabetes and already have some numbness in your hands or your feet, chemotherapy might not be the best option in this setting. And for patients who have advanced heart disease and what we call congestive heart failure, chemotherapy is not a good idea. So this is intravenous treatment delivered at the cancer center. The standard options are cisplatin and gemcitabine. Usually that's given what we call over 4 cycles. It's usually delivered on day 1 and day 8 every 3 weeks. Another option for patients who are fit for it is what we call dose-dense MVAC or 4 different chemotherapy drugs. These are different options which the medical oncologist will talk to you about. The reason we're bringing this up today is to show you that there are different options and make sure you're familiar with them and asking these questions. I wanted to talk a little bit about the bladder-sparing treatment. So a lot of patients didn't know that this was an option and maybe only heard about it after speaking with other patients who were able to preserve their bladder. Same patients might not be offered this, and maybe you're not sure why your urologist never talked to you about it. So bladder-sparing treatment is usually offered after the patient has had a TURBT. And again, the mainstay of this is radiation with a little bit of chemotherapy. So it's a long course of radiation, anywhere from 6 to 8 weeks of radiation therapy. The radiation is delivered at the cancer center. You're there for, an hour approximately at the cancer center every day, Monday to Friday, when the radiation is delivered. The radiation delivery itself is only a few minutes, but it takes a bit of time to get in there and get organized and get set up. That would be delivered with chemotherapy, usually weekly. So it might mean that on the Monday, you're there for a bit longer because you go to the chemotherapy area where you get a bit of radiation, and then later you have your radiation for that day. This is best suited. Some patients who are unfit for surgery might still be offered bladder-sparing treatment with radiation and chemotherapy, or it's also now being offered to patients who wish to preserve their bladder and who meet all of the following criteria. Who have had a complete resection, which means that the tumor was small enough that it could be completely resected by the turbate. It's less than 2 centimeters. There's no carcinoma in situ. It's stage 2 to 3, which means that on the CT scan, it does not look like the tumor is extending beyond the bladder. And also having no hydronephrosis, or these criteria are traditionally thought of important criteria before proceeding on with this bladder-sparing treatment. So our patients commented that during this experience with muscle-invasive bladder cancer, is really important to be offered that choice. And as a patient, it's important to know that you do have choices. It's important to know that there is the option of neoadjuvant chemotherapy. There's the option of bladder preserving treatment. Not all patients are good candidates for those treatments, but it's important to ask about those and to know why or why not you've been offered these. Another aspect that was really important was the post-surgical support. Once you've had your bladder removed, it's important to know where you can go for help and when. After you've been discharged from the hospital, what should you come back to the hospital for? What are important and alarming signs that you would come to the emergency room for? But where do you also go for routine things, like if your device is not working properly and you're wondering about different adhesives or different stoma appliances, who do you call for that? So these are questions to ask before you leave the hospital. A lot of cancer centers are getting really good at early discharge, but again, like I said, it's important to know where to go for help and ask these questions before you leave the hospital. Michelle's going to talk about this a little bit, but adjusting to life with a new bladder was a really important thing to think about. Even before you go for surgery, is to start thinking about these things. Is what are you going to need to do differently? And it can take a long time to physically adjust and emotionally adjust as well to having a new bladder or a stoma. I will now hand it over to Michele, who will talk about her experience.
Thanks, Nimira, and thanks everyone for this opportunity this evening. In a nutshell, this is me. I was diagnosed with high-grade invasive bladder cancer on Christmas Eve, actually, in 2011. In the end, I had chemotherapy and the removal of my bladder and the creation of a new bladder, or neobladder. So I actually call myself the inside bag lady. But this all happened when I was only 49 years old. So, given the opportunity to reflect on my journey and share with you this evening, I really pulled out a couple of things. The first one, and Nimira talked about a lot of this, is the duration and how long all of this actually took. For me, the course of my journey with bladder cancer really was over 1 to 2 years. First, the year prior to my diagnosis, really, I just had low energy. That was the only real symptom I can look back on. The second thing was that I really only had one, I'll call it a big episode of hematuria, where I had blood in my urine, just the one time. And it was a large amount, so it was really actually something that shook me. And the challenge with that is, even though I saw the blood in the urine, I still kind of, I think, was in denial. I didn't make any connection to bladder cancer. And basically, I thought it would just go away. Then it took about 4 months for me to get my actual diagnosis with muscle-invasive bladder cancer. And I have to say, it seemed like forever, even though I had things happening where I was going from one test to the next, as Nimira described, the ultrasound, the cysto, the turbid, and the pathology that finally came in. It did feel like forever. And that, you know, I also, even once I got the final diagnosis, then of course they had to do more investigative procedures to make sure that it hadn't spread anywhere. So all of this was actually quite intense and quite stressful to think about the what ifs as we're trying to just get to the diagnosis. Finally, I was into the treatment component, and that really involved the chemotherapy and the surgery. That was the option that I was given. But again, I was one of those people that Nimira described again with low kidney function from a childhood illness, and I only got through half of my chemotherapy treatment. So again, I was thinking, okay, what does this mean as far as my outcomes after surgery? But I did get myself to the surgery, and then obviously afterwards, it's a huge learning curve on trying to work with this new equipment. As a neobladder, I have a new bladder created inside, and there was no owner's manual that came with it. So at the time, I was one of very few women in Canada that had this new apparatus. And so I did a lot of trial and error and learning on my own. But I was able to conquer it, and I learned a lot about the new symptoms and what it felt like when I was full, and how to make this bladder work and how to go pee again. But it did take, I would say, 6 months to a year. Overall, I would comment mostly on the intensity and the uncertainty through all of it. All of the appointments, you know, seeing the different specialists, all the different tests, going to the Cross Cancer Institute here, or the oncology part of it for the chemo, and then of course all the surgery components. There was sort of two pieces to this that dovetailed very quickly. And I really had more questions than answers, and sometimes I just felt like I was hurrying up and trying to wait all at the same time. So it was really hard to hold all that together. And then I was concerned about making the best possible decision. I did look at the bladder preservation regimen. It, in the end, wasn't an option for me. You know, I was looking at how do I, you know, continue on with chemo? Could I get through it? Which I didn't. And then the big question, as many people have when you're looking at muscle invasive, how do you live without a bladder? And then what diversion, meaning the inside bag, like I have the neobladder, or the outside bag, the ileal conduit, what would be the right way to get the urine out for me? So again, I was looking everywhere I could to try to get some answers to make the best possible decision, because this was something that was really going to affect my life going forward. And all of this, it was my journey to have, even though I have a wonderful partner in my husband, Claude, but I was also concerned for him because, you know, he was having to watch me go through this and really was helpless in all of this to try to support me. And so I had my friends looking out for him too. And then learning how to live without a bladder, like I said, I think we're doing a way better job overall now about learning from each other, because there's more and more of us that have this experience. But it seemed pretty radical at the time that I was going to lose my bladder and that I was going to have to learn how to live without one. But it is doable, and like I said, there's more of us around that you can help learn from. And even to this day, just my annual checkups that I go for now, and I've been totally fine, but I still get my heart rate up, and you know, my blood pressure goes up, I think, when I have to go every year. My recommendations for you: breathe. And I still have to say this to myself. I need to slow down and just take one day at a time and try not to overthink it. My husband was really good at saying to me, Michele, this hasn't happened yet. So just slowing it down to realize that you know what you know today and you don't know what you don't know, and that you need to take some time to just realize that this is an evolving story with variable timelines that you kind of have to adjust along the way. I would advocate not a doctor Googling everything, because I find that that can be quite stressful. Your oncologists, your medical surgeons, even the clinical staff, they're just a wonderful resource for you when you come in with all of your questions. And that leads to the self-advocacy part again, which you've heard a lot about tonight, is that writing down your questions, recording things, having someone with you, and asking for what you need, because really this is about learning a new language and new skills. And that's, you know, on you to take that step forward to say, here's what I need to understand this better and make good decisions. And I would say about reaching out and talking to people, close family and friends. Bladder Cancer Canada, I can't say enough about the reliability and the excellent source of information just on the website that you can find, but also that peer-to-peer and peer support group opportunity that we have here in Edmonton. We literally learn from each other every month when we meet, and we can partner you up with people that are facing a similar journey, so you have someone to talk to directly. And even in the community, I say this because some people have been really scared to talk about their bladder cancer, but sometimes talking about your story can actually help save someone else who maybe doesn't realize what blood in the urine could be. And trying to stay positive. I know this seems like a momentous, you know, thing to ask of yourself, but this is a mind, body, and spirit journey. And one of the fun things that I actually did is I found the strength within, and I had a bye-bye bladder party. So I just decided that I was going to take this on full on and find a way to make things better. So with that, I'm 8 years out. I'm focusing on survivorship, quality of life, and giving back with my new bladder. Thanks so much.
Thanks, Michele. That's great. There are a lot of important learnings from what Michele said, and we reiterate some of that at the end. But I wanted to go and talk a little bit about signs and symptoms of recurrence. A lot of patients experience a huge amount of anxiety once they've completed the treatment for their non-muscle invasive disease or muscle invasive bladder cancer. And how do I live with this thought that this could come back, and how am I going to manage that, and what should I look out for? So let's talk a little bit about that. So if you've had non-muscle invasive bladder cancer, monitor for any changes in the urinary symptoms. You know, it could be as simple as you're having a urinary tract infection, but if you're having more burning, more frequency of urination, more blood again in the urine, these are symptoms which should prompt quick medical evaluation. So go to your family doctor, call your urologist, get in and get seen, and get your urine checked, because sometimes you do need to advocate for yourself, especially if you've had a low risk tumor, and we're not that concerned about it, but you do need to have that checked out, not only for peace of mind, but to ensure that the cancer hasn't recurred. If you don't have a schedule for ongoing cystoscopic surveillance, ask about when you should have your scopes done, if you should have an ultrasound or a CT scan done, and if you should have your urine cytology checked, because those patients who have higher risk disease might need that as well. So make sure you've asked those questions. And sometimes patients will print out a schedule on their fridge for the next few years, and that's not a bad idea, is to have that clear plan in your mind, but also be flexible. So for example, if you need an earlier scope, be open to that and be open to the plan changing, but knowing a general guideline of what should be followed is helpful. For patients who've been treated for muscle invasive bladder cancer and you've had a cystectomy, you should have ongoing evaluation of the upper tract, so imaging of the kidney and the ureters. But pay attention to any changes in your appetite or your energy levels. It's not normal to, for weeks on end, not be able to eat normally and to lose weight without meaning to. So that's an important sign or symptom to pay attention to. Also important is having lower energy levels that can't be explained. So you haven't run a marathon and you haven't just recovered from the flu. but really nothing else is going on and you just feel like your energy levels are not what they used to be and that seems to be getting worse, seek medical attention sooner rather than later. The other important symptom to pay attention to is pain. So if you've developed new pain anywhere, for example, you've got back pain and sometimes your back pain can be explained by a new workout or you were moving boxes and that pain goes away a few days later. If you have pain that's not going away and you can't explain it, if it's been a few days, get to your doctor, get to your family physician and get that evaluated. These are important things to not ignore. If you've been treated with chemotherapy and radiation, it's important to know that you will still need cystoscopic surveillance. So your urologist, your oncology team will go through with you a clear plan or should go through with you a clear plan for follow-up once you've completed the chemotherapy and radiation part of it. And part of that means still having scopes to look inside the bladder every so often to make sure there's no evidence of recurrence. So these are all really important things to watch out for, and don't be afraid to call your doctor and say, I'm just not feeling great. Could I come see you? I wanted to spend a few minutes as well now talking about advanced bladder cancer. Dr. Ong on his previous webinar has talked about new advancements in treatment, but for patients who have advanced bladder cancer, there are some important considerations before we end. All of the treatments that we've talked about today so far are to hopefully avoid getting to advanced bladder cancer, or what we call metastatic or locally advanced disease that is typically thought of as incurable. The goals of treatment for someone who has advanced bladder cancer are to decrease the symptoms that the cancer is causing now and also delay the time to symptoms. The goal of treatment is to improve the quality of life and to hopefully improve the duration of life. And usually for someone with advanced bladder cancer, the treatment is systemic, which means usually chemotherapy or intravenous treatments that go everywhere to treat those cancer cells wherever they may be. Patients with advanced bladder cancer are usually offered first-line treatment with chemotherapy such as cisplatin and gemcitabine or carboplatin and gemcitabine. And now our standard for second-line treatment is immunotherapy, and we have access to pembrolizumab here in Canada. So that's typically what patients would receive. When I talk about first-line treatment, that usually means what is offered first. And then if patients don't tolerate that, or if it stops working, then we move on to second-line treatment. You might hear about clinical trials, and clinical trials are how new medications are tested to ensure that they're effective and they're safe. We have sort of 4 phases of clinical trials, and you might hear about any number of these going through your cancer journey. Phase 1 are really early treatments, which are tested in humans, but on a small number of treatments, really to see does this treatment work in a small number of patients with advanced bladder cancer who've exhausted all other treatment options. Phase 2 trials are aimed to answer the question, is it effective and what are the main side effects? Phase 3 trials are how does this treatment compare to the current standard? And phase 4 trials are really long-term safety and efficacy. We've got lots of developments in bladder cancer recently, including immunotherapy, combination approaches with immunotherapy and chemotherapy. There are new treatments being discovered for patients who are not eligible for cisplatin. You might hear about antibody drug conjugates, and you might also hear about targeted therapy. So all of these new treatments are being investigated in advanced bladder cancer, and we have lots of data there now. So you might hear about them in earlier stages of the disease. So you might hear about them for patients with muscle-invasive bladder cancer, and even in non-muscle invasive bladder cancer, you might hear about clinical trials with these agents. What's really important to think about is also supportive care. So stay hydrated, eat well. If you're having pain, ask about pain and symptom control, and your doctors might say the words palliative care, but here in Canada, our palliative care teams are really our pain and symptom control experts. And so really we might involve them early on to help you manage your pain and your symptoms. Ask about home care, and if you have advanced bladder cancer, it's important to think about palliative care at home as well as hospice care. Advanced care planning means thinking about all of these things early. So If you're at a point where we have no good treatment options in terms of chemotherapy or radiation therapy left, then really what are you going to want to focus on, and how can you live your days to the best that you can, with the support that you want, and how do you want that to look like? So ask about advanced care planning early on in the journey as well. A few highlights that we haven't talked about yet, but that the patient's experience throughout the journey was waiting throughout the bladder cancer journey. You wait at all different stages, as Randy and Michele talked about. It can seem like forever. Those 2 weeks to get the pathology results can seem like forever. And then your physician is on holiday and you're waiting a bit longer and you know those results are there. It's important to be patient and know that our system tries to be as efficient as possible. But if you feel like you've been left in the dark, or you feel like there's an extra delay, it's okay to pick up the phone and call your physician's office and say, when can I expect to hear? A lot of times you feel alone as well, and reach out to other patients and other survivors as well. Our system is hopefully going to get better and more streamlined, but we're working on that, and we do recognize it as a negative right now, is that ideally it'd be great if your physician could call you as soon as the results are available, but we just don't have the capacity for that right now. So be patient, take notes, and use that time to reach out to other people and do your own research. For patients who don't live in a major urban center, so who live rurally, it's important to know what your options are close to home. So for example, if you've gone home after your cystectomy, know what resources are available close to home and know what you need to come in to the big city for. Think about your travel considerations. So if you're just having a turbot, you may not want to go home that day. You may want to stay with family or friends closer to the hospital that you've been treated at, and take that into account when you're making your plans for treatment. What's really important is to think about your own psychological and emotional health and the impact that a cancer diagnosis and a bladder cancer diagnosis can have throughout this journey. Hearing the word cancer, having all the treatments, the stress of being your own advocate, that can add up. We have so many resources in all parts of the country to help you manage this. So not only through Bladder Cancer Canada, but each hospital should have a psychosocial department. In Alberta, we have great psychosocial teams where we have free counselors, free social work resources that can help you navigate this part of it. There's also great resources in the community like Wellspring, that run classes such as art therapy that can help you deal with all of this as you're going through a cancer diagnosis. Don't be afraid to ask about the different resources that are there in the community, through the cancer center, or externally that may be of help to you. Sometimes it's actually looking at all those pamphlets on the wall that you see at the cancer center and saying, okay, that looks interesting, and reaching out for help. You're not alone. There's lots of people who've been through this, and if you want help, it's available. So to kind of summarize, the lessons that we learned through this patient engagement research is that there are lots of areas that we as a healthcare system and your healthcare providers can improve on. And most importantly is how much we communicate and when. And hopefully we'll move to a system where we have patient navigators who can help you throughout that journey. But until then, it's important that patients are your own advocates. So keep your notes, make lists, ask questions. Feel free to record your discussions. Reach out to others, ask about their experiences. Bladder Cancer Canada is a huge support system for peer support. Look at those other resources. Know your own body and know your own system. Ask about all the options. Most importantly, know that your healthcare team, we all went into this field to help you. And if that's not coming across, make sure you ask your questions and ask about the options. One question that came in before the webinar was, what is the optimal procedure for seeking a second opinion? And you know, if you are not comfortable with your provider, you can ask them to send you for another opinion, or you can ask your family doctor to send you for another opinion. We also have at most cancer centers across Canada what we call tumor board rounds or multidisciplinary rounds, where it's a multidisciplinary discussion. So a case might be presented when urologists are there, radiation oncologists are there, medical oncologists are there, and that's kind of a way of getting 12 different opinions at the same time. And you can ask for your case to be presented there if you're not sure that you're getting the right treatment for you at that time. Another hint I have is, you know, things are getting better, but also know what stage you're at so that you're asking the right questions and maximizing the time you have with your urologist. So that's all I wanted to say. Thank you all for your attention today. I'll hand it back over to Tammy.
Right, thank you, Dr. Alimohamed, so very much. With 2 minutes remaining, I'm just going to wrap things up here quickly. I really want to extend our sincerest appreciation to Dr. Alimohamed for joining us this evening. You do such an incredible job of delivering information in a way that it's easy to understand and absorb. And it's really because of caring and generous professionals like yourself that we can offer sessions like this at no cost to our community. Thanks also to our fabulous volunteers and survivors, Michele and Randy. Thank you so much for sharing your experiences and learnings so that others can apply them in their own journey. And finally, a shout out to our industry sponsors. Without their support, we wouldn't be able to offer events like these at no cost. Please be reminded that you will receive a recording of tonight's webinar as well as feedback survey within the next week. We ask that you take a few moments to complete the survey so we can continually improve the services we offer. Also note that all of our previous webinars are available for you to view on our website at bladdercancercanada.org, including the ones that Dr. Alimohamed mentioned for Dr. Ong and Dr. Powers. So you can find all of those there, and this one will also be posted there within the next couple of weeks. Just to review here, should you need information or support at any time through your treatment and recovery, we're here for you. Our trained one-to-one peer support volunteers are just a call or an email away. We also encourage you to join our online discussion forums or to subscribe for our newsletter on our website, again at bladdercancercanada.org. And lastly, we invite you to volunteer with us if and when you're ready. There are so many ways in which you can help us to fulfill our mission to support patients, increase awareness of bladder cancer, and fund more research. We're wishing you all the well this evening, and please stay in touch.